Good morning, everyone. My name is Dr. Zishan, and today's topic of presentation is castrate-resistant prostate cancer. Starting with the learning objectives, mechanism, diagnosis, imaging, and treatment. The introduction for the prostate cancer is the second most common malignancy and is the second leading cause of cancer mortality among men in US and Europe. Approximately 7% of men in US initially present with metastatic disease. In some Far East countries of Asia, the rate of metastatic cancer on presentation is as high as 64%. For the past 70 years, androgen deprivation therapy has been the mainstay of therapy for metastatic prostate cancer. Older generation androgens such as balutamide were the standard approach to treating metastatic CRPC. The median survival in metastatic CRPC is approximately 35 months. The definition is castrate-resistant prostate cancer is defined by three consecutive PSA rises from its neither asymptomatic progression of despite a favorable biochemical response or appearance of new metastatic lesion following androgen deprivation therapy in the presence of castrate serum testosterone level less than 50 nanogram per deciliter. If we talk about the mechanism, we got two pathways, AR dependent and androgen receptor independent pathway. Ultimately, both pathways will alter normal androgen signaling. If we talk about the androgen dependent pathway, during androgen dependent progression, prostate cancer cell depend primarily on the androgen receptor for growth and survival. When the androgen receptor is inactive, it is bound to heat shock protein in the cytoplasm of prostate cells. The dihydrotestosterone bound androgen receptor translocate into the nucleus, dimerizes, and bind to the androgen response element, thereby activating genes involved in cell growth. This is androgen independent pathway. During androgen independent pathway progression, prostate cancers relies on various cellular pathways, some involving the androgen receptor and other bypassing it. Previously, we have discussed these three pathways, namely androgen receptor amplification, androgen receptor mutation and alternative splicing, and intramural androgen production. These were the androgen amplification hypersensitivity pathway, which already discussed before.
ये इसमें ये जो साइड पे लिखा है ना जिशान, दैट वाज वी वर डिस्कसिंग बिफोर।
Yes.
ये जो सब WNT BCL2 AKT और एक इसमें बीटा कैटेनिन का भी रोल था। तो दीज आर दी ऑल्टरनेटिव पाथवेज एंड नाउ दे आर नॉट डिपेंडेंट ऑन दिस व्हाट यू वर मेंशनिंग अबाउट AR रिसेप्टर्स और ये। तो ये इंट्राट्यूमरल एंड्रोजेनेसिस स्टार्ट हो जाती है बिकॉज ऑफ दिस ऑल्टरनेटिव पाथवेज।
If you identify the right diagnosis with criteria CRPC, serum testosterone less than 50 nanogram using androgen deprivation therapy, one or any in combination, either biochemical progression, three consecutive rays in a PSA, and radiological progression 1 week apart, radiological progression when the presence of more than two bony lesion, presence of soft tissue lesion with nodes greater than 2 centimeter in diameter. The classification for CRPC is non-metastatic CRPC and metastatic CRPC. CRPC with rising PSA without any mets and bone or soft tissue visible on imaging lymph nodes. If we talk about the imagings, the radar group suggested that the imaging.
So before moving ahead, we should know the basic difference between the biochemical recurrence and castrate-resistant CAP. These are two separate entities. So biochemical recurrence or biochemical progression was what we were playing with the dynamics of PSA. Mean a patient usually don't have any symptom; they are asymptomatic. But on following up or on surveillance, you find that their PSA is raised. That same definition applied there as well. But if a patient primarily underwent XRT radiotherapy, then we consider Phoenix criteria, which is a raise of PSA of greater than 2 nanogram per mils. Or if a patient underwent surgical like radical prostatectomy, then a cutoff of 0.2 is used. So that will be a biochemical recurrence. So patient is asymptomatic, but on following up, you are getting a raised PSA. So that is a biochemical recurrence. But in case of CRPC, that is castrate resistant prostate cancer, it could be metastatic or it could be non-metastatic. The definition is same. There is a rise from the PSA regardless of the management. That patient underwent surgery or whatever management. The main domain is that patient was castrated either surgically or medically, and you have ensured that patient is castrated by this definition you just mentioned, that the serum testosterone level is less than 50 nanogram per deciliter. And then a patient might have some radiological progression, might have symptoms, then you can label that patient is castrate resistant.
Moving towards imaging, the radar group suggests that imaging should be initiated when the considering starting therapy for patients with CRPC when therapies are changed to establish a new baseline and after treatment has been completed to monitor disease progression. The radar group has recognized that radio-labeled choline positron emission tomography was found to be more sensitive than conventional imaging. Ultrasound CT scan of the abdomen, pelvis, and bone scan in selected patients with biochemical recurrence. Current guidelines dictate that the patient should be screened early. Factors should be taken into consideration when deciding on the frequency of imagings. Individual risk, age, PSA doubling time. Scans should be performed more frequently when the PSA doubling time is less than 8 months. Gleason grade and overall patient health. Imaging in non-metastatic CRPC, the REDI guidelines recommended obtaining the first scan when the PSA level reaches 2 nanogram per milliliter. Imaging modalities recommended for the initial testing include bone scintigraphy and abdomen pelvis chest CT. If the imaging is negative, PET with colon tracer, targeted prostate specific membrane antigen, and whole body MRI. This should be followed by another scan when the PSA level reaches 5 nanogram per milliliter, and for every doubling of PSA level thereafter. Delays in ordering bone scan are common in clinical practice, resulting in delayed diagnosis of metastasis and delayed therapy, which can negatively impact patients' outcome. Now we are talking about the treatment. Suppression of gonadal testosterone is the central principle of androgen depression therapy. The development of androgen depression therapy resistance is a universal state that affects all the patients treated with androgen depression therapy. A complete disease evaluation is required to estimate the outcome and to make therapeutic decisions. Critical baseline components are extent of disease, mode and site of progression, rising PSA level alone, new bone metastasis, visceral and nodal metastasis, presence or absence of symptoms, response and compliance to prior endocrine treatment. The general consensus is to maintain all the patients on LHRH agonist or antagonist indefinitely, even during the course of subsequent therapies, including chemotherapy. Verify castrate levels, and if
This was the point we were discussing before your presentation, that you have to continue with this thing, and there were 3 to 4 reasons. One, that is still that it will control the disease, and if you stop this ADT, patient might have flare up and tumor grow enormously. So these are the reasons that you have to continue with the ADT, even in the presence of the castrate resistant CAP, combining with other therapies.
verify castrate levels, and if not less than 15 nanogram per liter, then alternative LHRH agonist, antagonist, or orchidectomy. If we talk about the non-metastatic CRPC, an increasing number of patients now begin ADT at very early stage of their disease course, often at the first sign of a rising in PSA after local therapies before metastasis. Unlike recently, there was no consensus regarding the most appropriate management for patients with non-metastatic CRPC, although the sequential endocrine approaches using first-generation non-steroidal androgen receptor antagonist agents baclotamide and ketoconazole was most commonly used modalities. This all changed in 2018 when FDA approved Abiraterone and Enzalutamide non-steroidal second-generation potent androgen receptor antagonist. If we talk about the dose of enzalutamide, 160 mg per oral once a day may administered with or without food. If we talk about the mechanism of action of enzalutamide, it acts on three places. Enzalutamide inhibits AR testosterone binding with higher affinity than biglutamide. Enzalutamide receptor inhibits block the activation change induced by androgen receptor testosterone binding, and enzalutamide inhibit androgen receptor testosterone nuclear translocation and DNA transcription. There is also work of biglutamide. Enzalutamide lack partial androgen receptor agonist activity that occurs with biglutamide resistance. So this mechanism lacked by enzalutamide. Metastatic CRPC is treated by cytotoxic chemotherapy. The most common met site in these patients is bone, manifested by diffuse osteoblastic lesion. Soft tissue or visceral metastatic is uncommon. The chemotherapeutic agents, most of the chemotherapeutic agents available in oncology practice that have been used in patients with CRPC, either as a single agent or in a combination. The above agents are no longer being used: cyclophosphamide, 5-fluorouracil, doxorubicin, cisplatin, and carboplatin. Mitoxantrone and docetaxel are used nowadays. Mitozentron, first step forward in chemotherapeutic management of CRPC, came with mitozentron with its maximal palliative effect in combination with low dose steroids. Even though the use of first line mitozentron has dramatically declined with advent of more effective chemotherapy agents such as docetaxel and carbazitaxel. Mitozentron is still sometimes useful for patients with docetaxel and carbazitaxel refractory disease. If we talk about docetaxel, docetaxel is a standard first-line chemotherapy for metastatic CRPC. It prolongs progression-free and overall survival, ameliorates pain, and improves quality of life. Docetaxel is believed to have a two-fold mechanism antineoplastic activity. Inhibition of macrotubular depolarization disrupt the transport of ligand-bound AR from cytoplasm into nucleus. They induce apoptosis. This is a dose of docetaxel. Initial dose as a single agent 75 mg per meter square given every 3 weeks. These are side effects of it: myelosuppression, fatigue, peripheral edema, neurotoxicity, hyperlacrimation, nail dystrophy, and neutropenia. Cabazitaxel has emerged as a second-line chemotherapy option for patients with metastatic CRPC who have had progressive disease during or after docetaxel treatment. This drug shown to be active in docetaxel sensitivity as well as docetaxel resistant tumor. The dose of it is 25 mg per meter square administered as a 1 hour intravenous infusion every 3 weeks in combination with oral prednisone 10 mg administered daily throughout. And the side effects of it are neutropenia, diarrhea, fatigue, nausea, and hypersensitivity. The next generation hormonal therapies, it has been recognized that the androgen receptor and ligand dependent androgen receptor signaling commonly remain active and upregulated in men with castrate level of testosterone. Standard hormonal therapies such as LHRH agonist antagonists inhibit gonadal androgenesis but do not affect androgen synthesis from adrenal or other extragonadal intratumoral sources. That may account for up to 10% of total androgen production. Abiraterone, it is an oral selective inhibitor of cytochrome P450 isoform 17, a key regulator of extragonadal androgen synthesis, given as 4 tablets per orally once a day, with prednisone 5 milligram per oral once 12 RD. This is a mechanism of action. Abiraterone binds to 17 alpha dihydroxylase, C17 and 20 bias. In end, it decreases the formation of aldosterone and dihydrotestosterone. Abiraterone, with this drug, PSA declines more than 50%. टेस्टिकुलर ये सब रोक लें इसको, लेकिन जो आपके एडिनल से आ रहा है वो ए पाथवे है, इसको एपिट्रॉन रोकेगा, रोकेगा ये दाएं पे एक्ट करेगा सेल्फिन 17 अल्फा हाइड्रोक्सिलेट और C1720 लाइस से, ये कन्वर्ट नहीं होने देगा प्रेनिसोलोन को, और DHE जो हमने पढ़ा था इस पे कन्वर्ट नहीं करेगा, इस पे कन्वर्शन नहीं होगी तो हमारा टेस्टोस्टेरोन नहीं बनेगा. ठीक है.
So previously, historically, we were even in our center, we were using ketoconazole for the same purpose. That is an antifungal, but that has an additional effect that blocks the production of this androgen via adrenal pathway. But there was a side effect profile was more, and so this comes into it. So these are the newer one.
Now moving towards immunotherapy, cancer immunotherapy refers generally to approach that attempt to treat cancer by activating immune response against malignant cells while overcoming tumor-induced tolerance. It produces several tissue-specific proteins that may serve as tumor antigens. These include PSA and prostatic acid phosphate and others. Talking about the vaccine, Sipuleucel T is an active cellular immunotherapy agent, autologous peripheral blood mononuclear cells activated in vitro by a recombinant fusion protein. It is administered in 3 doses at approximately 2 weeks interval. Talking about the palliative management, pain and epidural cord compression. Patients with back pain and a history of bone metastasis should be evaluated for epidural cord compression. The clinical syndrome often includes at least one of the following signs and symptoms: back pain, focal neurological defect, leg weakness, sensory levels, or changes in bladder or bowel control. Initial management of suspected cord compression includes immediate MRI of the spine, and initiation of high dose intravenous corticosteroid therapy. Injection DEXA ranging 16 to 100 mg daily. Patient often administered 10 mg of DEXA loading dose followed by 4 to 10 mg 6 hourly. On improvement of symptoms, taper down the drug into 2 to 3 weeks. Definitive treatment should include radiation therapy, surgical decompression, or both. Bone targeted approaches. In bone pain, vertebral collapse deformity, we use bisphosphonates. Pathological fracture, we use cimentations. And in spinal cord compression, decompression depending corticosteroids. Bisphosphonates work like inhibit osteoclast, mediate bone resorption, highly effective in reducing bone pain. Zoledronic acid 4 mg is IV bisphosphonate, and jaw necrosis is treated by amino bisphosphonate. There is no survival benefits. If we talk about the radiopharmaceuticals, radium 223 is a novel alpha emitting radiopharmaceutical that the FDA has approved for the treatment of symptomatic bone metastasis in CRPC, patient without visceral metastasis or bulky lymph node disease. The recommended dose is 50 kilobecquerel per kg intravenously every 4 weeks for a total of 6 cycles. For this, I would like to show the video and get to understand more.
Radium-223 is a groundbreaking treatment for metastatic prostate cancer, particularly effective against bone metastases. This alpha-emitting radionuclide selectively targets bone tissue, delivering localized radiation while minimizing damage to surrounding healthy cells. Its unique mechanism involves the mimicry of calcium, allowing it to bind to areas of increased bone turnover, which is common in metastatic lesions. Clinical studies have demonstrated that radium-223 not only extends overall survival, but also significantly improves quality of life by alleviating bone pain. The treatment is administered via intravenous injection, typically in 6 cycles, and its safety profile is well established, with manageable side effects.
This was a video for radiopharmaceuticals. Radium-223 dichloride is a radioactive isotope that emits low level of alpha particle radiation. The alpha particle radiation causes double-strand break in DNA killing cells. It accumulates preferentially in areas of bone that are undergoing increased bone turnover, where bone mets form. According to European Association Urology guidelines, life-prolonging treatment of castration-resistant disease ensure that testosterone levels are confirmed to be less than 50 nanogram per deciliter before diagnosing castration-resistant prostate cancer cells. Counsel, manage and treat patients with metastatic CRPC in a multidisciplinary team. Cytotoxic treatment of castration-resistant disease offer patients with MRCPC who are candidates for cytotoxic therapy, docetaxel with 75 mg per meter square every 3 weeks. Offer patient with MC, metastatic CRPC and progression following docetaxel chemotherapy for the life-prolonging treatment options, which include abiraterone, cabazitaxel, enzalutamide, and radium-223. Base further treatment decision of metastatic CRPC on pre-treatment PS response to previous treatment, symptoms, comorbidities, extent of disease, and patient preference. Offer cabazitaxel to patient previously treated with docetaxel and progressing within 12 months of treatment with abiraterone or enzalutamide. Supportive care of castration-resistant disease offer bone protective agent to patient with metastatic CRPC and skeletal metastasis to prevent osseous complications. Monitor serum calcium and offer calcium and vitamin D supplementation when prescribing either denosumab or bisphosphonates. Treat painful bone metastasis early on with palliative measures such as EVRT and educate use of analgesics. In patient with spinal cord compression, start immediate high dose corticosteroids and assess for spinal surgery followed by irradiations. Offer radiation therapy alone if surgery is not appropriate. Non-metastatic castrate-resistant disease offer abiraterone, enzalutamide, or enzalutamide to patients with non-metastatic CRPC and a high risk of developing metastasis. PSA doubling time less than 10 months to prolong time to metastasis. Thank you.